ENT. Today we'll be seeing two chapters. One is ENT followed by the ophthalmology. First, what we'll be seeing is the ENT, ear, nose, and throat. Pharyngotonsillitis. So pharyngitis, tonsillitis is seen as together here and we are learning together. Pharyngitis is nothing but inflammation of the posterior wall of the pharynx. So it can be because of viral bacterial infections, and we are seeing together along with it is the tonsils inflammation. Tonsil inflammation, it can be again an infective cause. For example, it might be a bacterial or viral infection. So usually common terminology used by the patients is they are having a sore throat. They might be associated with some amount of fever because of a viral or bacterial. They might be having difficulty in swallowing. Okay, it's more of pain while swallowing rather than difficulty in swallowing. So the right terminology will be odinophagia rather than having a dysphagia. It's an odinophagia, basically pain while swallowing. Which are the bacteria which might cause it? It might be caused by a group A beta hemolytic streptococci. It is well known to cause complications. Mycoplasma, Corynebacterium diphtheriae. Viral viruses like EBV virus, Epstein-Barr virus, which stands for HSV, or adenovirus. So various viruses also can cause this. Whenever a patient presents with symptoms suggestive of pharyngitis, tonsillitis, or together pharyngotonsillitis, we always depend on the fever pain criteria whether to give the antibiotics or not. In a stem of the question, if they specifically mention use and center criteria, then only you are using it. Otherwise, do not use it. This is the one what you need to use it. If they're not mention anything, use this one. If they mention fever and pain criteria, still you're using the same one. If they specifically mention about center criteria, then only use this. Otherwise, do not use. The fever pain criteria itself is a mnemonic where F stands for a fever spike in last 24 hours. That carries a point. A purulence, that is pus on the tonsils. Here in the previous image, what we have seen, yes, there is pus. The yellowish color, what you're seeing is the pus on the tonsil, which has a point. Attended rapidly. That means he has the severe enough symptoms to attend to the emergency department within 72 hours. Another point. Inflamed tonsils. This are inflamed and enlarged tonsils along with the purulence, what is present here, that gets an point. Remember, this is important, which usually forgets no cough or coryza. If cough or coryza is present, it is unlikely to be in bacterial. That's why they have specifically mentioned as no cough or coryza. That is inflammation of the mucous membrane in the nose. Gets another point. This is a fever pain criteria. Let us see the components of centers criteria. Tonsillar exudates, nothing but purulent exudates, what we have seen in the previous slide. Tender anterior cervical lymphadenopathy or lymphadenitis, which is commonly seen in the bacteria. History of fever, especially if it is more than 38 degrees Celsius, gets in point. Again, here, absence of cough gets another point. So first, what we'll be seeing, we'll see according to the fever pain score, how do we give antibiotics or how do you manage the patient? First one, what you are seeing, a fever pain score of 0 and 1. If 0 and 1 is there, antibiotic is not advised at all. Your fever pain score is 2 and 3. Then we consider giving antibiotics. A clinical decision needs to be taken. Most of the time, what we do is we give the backup prescription or backup antibiotics. We tell them that if the symptoms do not improve within 3 to 5 days, or the symptoms get worsened, for example, by tomorrow the symptoms have got worsened, start taking this antibiotic. Those are known as backup antibiotics. If the pain score is 4 or 5, what we do? We immediately start them on antibiotics. Usually it is not a backup. We immediately start them on antibiotics. Let us see the center score. Center score has only two categories. Either you're not giving the antibiotics or you're giving the antibiotics. So center score 0, 1, 2, you do not give the antibiotics. 3 and 4, you directly give the antibiotics immediately. Remember, fever pain has three categories. One is not to give the antibiotics. Another one is backup antibiotics. Another one is to give immediate antibiotics. Why we do not give antibiotics? The question might be raised by the parents. Why are you not giving my kid the antibiotics? Thing is, if we give unnecessarily the antibiotics, the chances are that they can develop diarrhea and nausea. The side effects of antibiotics, the very simple side effects which can be seen in most of the antibiotics, like GI symptoms, nausea, and diarrhea, they can develop. It doesn't mean that starting the antibiotics will shorten the duration. For example, someone has a viral infection. If you start them on an antibiotic, viral infection which is supposed to last for 5 days will last for 5 days. It will not reduce. And it is unlikely to prevent any complications. Okay, so to prevent a complication, to reduce the duration, you shouldn't be giving the antibiotics. That's why antibiotic, when it is indicated, then only you have to give it. If it is not indicated, do not give it. Chances are that they develop resistance to the antibiotics over the time. So because of all these reasons, we do not prefer giving antibiotics blindly unless we do an fever pain score and decide on that. If the fever pain score says give the antibiotic, the first choice becomes an phenoxymethyl penicillin. The alternative, that is, if someone is allergic to penicillin, clarithromycin you are giving it. Clarithromycin is not preferred in the pregnancy. So someone who is allergic to penicillin and pregnant, then you are going ahead with the erythromycin. Investigations for tonsillitis. When do we investigate? Most of the patient doesn't require an investigation. It's completely an clinical diagnosis. You do not want to do any investigations. You do an throat swab or ASO titers, you'll do it if you're suspecting a severe infection. Okay. If you're suspecting someone is immunocompromised, can develop severe complications. At that point of time, doing a throat swab to find out whether it is in group A beta hemolytic streptococcal infection or not, then it makes sense. When you're suspecting an EBV, then we can get a monospot test done. Again, we will be studying in coming up slides what investigations we'll be doing for EBV. Remember that monospot test is also known as Paul Bunnell's test. What are the ENT complications? The infection can spread to the surrounding organs. For example, from the throat. So in the throat, you have the pharynx and the tonsils. From the throat through via the Esteban tube can go into the middle ear infection, resulting in otitis media. The infection over the tonsils can result formation of the abscess behind the tonsils. This is known as quinsy, also known as peritonsillar abscess. Retropharyngeal abscess behind the pharynx pus might get accumulated, resulting in retropharyngeal abscess. Can spread to the sinuses, which is close to it, resulting in sinusitis. Systemic complications most of the time is seen by infection due to group A beta hemolytic streptococcus, which we have kind of already studied in dermatology chapter. It can cause scarlet fever, rheumatic fever, post-streptococcal glomerulonephritis. It can also cause like an cellulitis. And infectious mononucleosis is secondary to Epstein-Barr virus infection. So let us see infectious mononucleosis. Infectious mononucleosis is also known as Kissing's disease because it is commonly spread when the saliva is exchanged, commonly seen while kissing. So the common age group is between the teenage and young adults who frequently kiss around. For that particular reason, this is also known as Kissing's disease and seen in this age group. The causative organism is Epstein-Barr virus. Epstein-Barr virus is not a notifiable disease, or infectious mononucleosis is not a notifiable disease. It's not a notifiable organism, EBV. Remember that multiple times tested previously. We have already learned this in our infectious disease chapter. How do we predict if it's an infectious mononucleosis? Someone who has a sore throat and generalized lymphadenopathy, hepatosplenomegaly, then you need to strongly suspect it can be an infectious mononucleosis. Pregnancy, high risk for HIV, then investigations you need to do it. That means anyone who is at high risk, for example, he's immunocompromised. For example, he has an congenital heart disease, chronic lung disorders are present, like cystic fibrosis, especially in the children. Then you need to go ahead and further evaluate. Anyone who is less than 12 years or you're suspecting an immunocompromised status, directly serology is preferred. More than 12 years and you're not suspecting any immunocompromise, then you will be doing an heterophile antibody test or a monospot test. So what will we be doing? Remember, heterophile antibody test is also known as monopause test, is also known as Paul Bunnell's test, all means one and the same. So first you need to suspect someone who has an pharyngitis, fever, and having a lymphadenopathy, you can add up and having an hepatosplenomegaly. Someone having these symptoms, what you do? You directly go at more than 12 years, I'm talking about. Less than 12 years, you directly go for serology. Don't forget, less than 12 years, you're directly going at with serology. More than 12 years, what do? You get an heterophile antibody test. If it is positive, then you have the diagnosis. Nothing needs to be done. If it is negative, it doesn't rule it out. You need to closely have a look at the lymphocytes. If the lymphocytes are less than 4,000, you rule it out and think of some other diagnosis. If it is more than 4,000, then you need to go ahead and get the serology done. If serology is positive for IgM, suggestive of a diagnosis, or it is undiagnostic. If it is negative, then think of something else. It has ruled out an Epstein-Barr virus infection, that is infectious mononucleosis, highly unlikely in this scenario. Treatment. The mainstay of treatment here remains is supportive treatment. You do not do anything. It's a viral infection. You do not have anything specific antiviral medication for an EBV. We give steroids whenever there is a significant amount of swelling which has developed, which is resulting in an airway compromise. At that point of time, giving steroids makes sense. Otherwise, do not give steroids. One of the important complications of an Epstein-Barr virus infection, that is infectious mononucleosis, is enlargement of the spleen. It results in abdominal pain. An enlarged spleen, whenever even a minor trauma, can result in rupture. So they can have a complication of a splenic rupture. So they need to be very careful. So they need to avoid contact sports at least for a month. If they want to go ahead with the contact sports before a month time, then they have to get an ultrasound scan done to rule it out and splenomegaly. Then only they're allowed to go ahead with an contact sports like in rugby, football, basketball. They're allowed only after it is confirmed on an abdominal ultrasound scan within a month's time if they want to go back. Because in a splenomegaly, chances of splenic rupture will be very high, especially in a contact sports. Do not give amoxicillin in individuals with a suspected infectious mononucleosis because it results in an rash. Okay, this is an autoimmune kind of rash. It is not an allergic rash what they develop. It's a macropapillary rash. It is kind of an florid rash, what we call it. It's an autoimmune rash, what you are having it. It is not because of an allergy. Few things, key terminologies you need to be aware of. Someone who is having an PTK or someone who is basically on the hard palate or on the phalanx, they have an PTK. PTK is the red color spots what you're seeing here. This red color spots what you're seeing is known as PTK. If present, you need to strongly think of an group A beta hemolytic streptococci or an EBV virus infection, that is infectious mononucleosis. Any swelling behind the tonsil. So this what you are seeing is a tonsil. Behind this what is present is the swelling. What is this swelling? This is accumulation of the pus which is present here. This is known as quinsy, also known as peritonsillar abscess. Gray color pseudomembranous on the pharynx. This is suggestive of an diphtheria, which we have already learnt. A strawberry tongue. Anyone comes with a strawberry tongue, you have two differential diagnoses from exam point of view. Either it is an scarlet fever or it is an Kawasaki's disease. If there is a posterior pharyngeal wall swelling or neck stiffness is present or neck swelling is present, then think of an retropharyngeal abscess in this individual. Whenever a triad nurse comes and says you there is a patient with a sore throat, do not take it lightly. They might come walking into the minor saying that I have a sore throat. But when you go and see the patient, he might be having a noisy breathing, suggestive of an airway narrowing. Stridor might be present, suggestive of an air narrowing. He might be drooling saliva, suggestive of a difficulty in swallowing. He might be in the tripod position where he has taken up this position of a sniffing position basically to open up the airway. This is all suggestive of an impending airway arrest. You need to take it very seriously. Okay, so do not just disregard it. Always have a look. Unless it is a senior nurse who comes and tells it's just a sore throat, do not take it lightly. If a junior nurse says it, always have a go and look up patient and see whether he's stable or not. These patients, whenever they come with signs and symptoms as written here, suggestive of an airway compromise, immediately involve the senior doctors and ENT specialists, especially the anesthetics and the ENT needs to be involved because if their airway goes completely compromised, securing an airway becomes very difficult. They might require in front of neck access. The quinsy, as I told you, this is the tonsil what you're having. Behind this, there is a swelling which is developed. It is usually an unilateral what we'll be having. If it's a unilateral, the uvula will be deviated to the opposite side. They present with, as it is an abscess, high-grade fever, unilateral sore throat, and increasing pain on swallowing. Those are the difficult, those are typical terminologies what they'll be using. Remember that if this abscess enlarges a lot can cause airway compromise. So look out for the symptoms like inability to swallow, drooling of the saliva, tripod position, having a stridor. These are all suggestive of an upper airway compromise or impending upper airway compromise. If you are suspecting there is an impending upper airway compromise, immediately shift this patient to the resuscitation room. Involve the senior anesthetic and ENT surgeons before you even do anything for this patient. If the patient is desaturating, start him on high flow oxygen. Make sure he's in the resuscitation room. Involve the senior anesthetics and ENT surgeon at the earliest. This is an abscess, so requires an drainage done by the ENT specialist. Along with it, you need to give IV antibiotics. The preferred one will be benzyl penicillin. Post-tonsillectomy bleed. Tonsils, there are various indications to remove it. So it is done as a daycare procedure. So post-removal, they can end up having a bleeding. What they will do, they come back to the ED department. okay, out of hours, they will directly walk into the emergency department. So you need to be aware how to manage a patient post tonsillectomy. He comes in bleeding. So broadly, it is divided into an refractory bleeding and delayed bleeding. Refractory bleeding is bleeding within 24 hours of post operation. What has happened here? Usually they use adrenaline there, okay, adrenaline or certain drugs they use which causes an vasoconstriction. Once these drugs affect veins off, it dilates back. Once it dilates back, it can start bleeding. Or a suture might give away, starts bleeding. Or there was a clot which stopped bleeding and it has just while swallowing, or the patient had something to eat orally, might have got dislodged, starts bleeding. So most of the time, this is within 24 hours. This is known as refractionary bleeding. If it is after 24 hours up to 2 weeks, then it is known as delayed bleeding. Delayed bleeding, the most commonest cause is infection. So it is recommended that you start on IV antibiotics for these individuals also. That is important. You need to be remembering what you do. For any patient who has a bleeding from head, okay, anywhere, it might be nose bleeding, it might be oral cavity bleeding. What you do, you make the patient sit upright. Do not give anything to eat and drink because he might require surgery. Upright is important to prevent the aspiration. So make the patient upright. Okay, don't make him lie down flat. He can end up aspirating for that particular reason. Then go ahead with an ABCDE approach like any other emergencies, clear the airway. Then the specific things we are talking about, that is how to stop the bleeding. That comes in circulation. So make sure you have an two large bore IV cannulas and get an full blood count clotting profile and blood group and cross matching. Fluid resuscitation, you will start before you have the blood products available if the patient is hemodynamically compromised. That means if the systolic blood pressure is less than 90, start giving IV fluids initially till the blood products are available. Once blood products are available, you will be following the major hemorrhage protocol, which you have already learned. Now comes we want to stop the bleeding. So you need to have a clear visual field. So remove any blood which is present here. Do a gentle suctioning and remove of the blood. If the patient is conscious enough, that means if the GCS is 15, give him to gargle water which is mixed with hydrogen peroxide in the ratio of 1:1. That usually helps to stop the bleeding. If that doesn't stop the bleeding, then cotton wool pledge, just soak it with adrenaline, or you can use an hydrogen peroxide and just place it over the bleeding side. That is a tonsillar fossa. On the tonsillar fossa, just place it there and apply a little bit of pressure using an forceps. So use a forceps, hold it, soak it into a hydrogen peroxide and topical adrenaline, whichever is available. Then place it on the tonsillar fossa for few seconds, if not few minutes. That will help. If that doesn't help, make sure you have a clear field within good vision. If you can visualize the bleeding spot, you can do a chemical cauterization using a silver nitrate stick. If this also doesn't help, then you need to refer to the ENT immediately. They need to come down to the emergency department. In any scenario, you need to always refer to the ENT because this patient has been operated by the ENT surgeon. So you need to involve this. Start intravenous antibiotics. It is recommended that you start on intravenous antibiotics because delayed bleeding, most commonest cause is infection. That's why it is important that you start on intravenous antibiotics. Otitis externa. So ear is divided into external ear, middle ear, inner ear. Any infection of this part of the ear, that is the external ear, is known as otitis externa. The most commonest organisms which can it cause is strep pneumonia or staph aureus. Sometimes it might be caused by Pseudomonas. If it causes a Pseudomonas, it can cause a complications known as malignant otitis externa. It doesn't mean and it is a malignancy. It is not a malignancy as such. Okay, it is just an osteomyelitis of temporal bone. It's a severe infection which is involving the bone which is adjacent to the external auditory canal. This bone is temporal bone, so it involves it causing the infection of that bone, commonly seen because, because of Pseudomonas infection. What you do, you need to give IV antibiotics here and urgently you need to refer to the ENT. We'll come back to the normal bacterial infection, not as Pseudomonas. How do they present with? Some debris will be there, some discharge from the ear is present in those individuals. Itching might be present, pain might be present. While you examine using an otoscope, the canal might be inflamed and a lot of debris you obviously you will be seeing inside the canal. What you advise to the patient, tell him keep the ear dry. Okay, avoid inserting anything into the ear. Just itching, don't put a pen and start itching. It can damage the tympanic membrane. So avoid inserting anything into the ear. Analgesia. So they are having a pain. So topical ear drops, like you can use it, and NSAIDs topical ear drops are available. You can usually use it. Okay, preferred ones, what they do is, along with an analgesia, they also prescribe an antibiotics, and they can combine with a steroid. But be careful to use an aminoglycosides. Do not use an aminoglycosides if there is an perforation of the tympanic membrane. So always, before prescribing an topical, that is the ear drops, if you're prescribing, you need to visualize the tympanic membrane. Make sure there is no perforation, then only you are visualizing it. Sometimes the debris might be a lot. Then what you do something known as oral toilet. Basically wash out the external ear canal, then place and wig. This is nothing but an cotton wool, cotton wool which is present, or it is in gauze piece. You just make an wig and place it in here so that the debris gets absorbed there. So you need to clean it before you can really visualize the tympanic membrane if it is a severe infections or debris are plenty. Otitis media. Now we are in the middle ear. Okay, otitis media it is known as. Most commonest organism causing otitis media is strep pneumonia, followed by Haemophilus influenza. Viruses wise, it is an RSV virus or rhinovirus. And 75% of the cases are seen in the age under 10 years. How do they present? They present with an ear pain. If it is an elderly, someone who can verbally communicate to you, ear pain they'll be telling, along with usually they'll be having a conductive deafness. Remember that conductive deafness is seen because of recurrent, not a single episode, a recurrent otitis media. I had 10 previous, 5, 6 times I got infected. Then they can develop an conductive hearing loss. Okay, usually it is because of the development of cholesteoma, which we'll be talking in the coming up slides. In younger kids, like 1 year, 1.5 year, who are not verbal yet, they present with non-specific symptoms. Might be highly irritable, poor feeding, appetite has calmed down, the baby is not drinking anything, eating anything, fever is present, lethargic, mom doesn't know anything. So what we do usually, we examine the ear, we examine the throat. So ENT examination becomes very important in the pediatric age group when they present with a fever and you do not know the foci of infection. Tympanic membrane, when you examine, what happens? The tympanic membrane is red. That is erythematous. Red means erythematous color. Bulging. Along with it, a light reflex will be usually absent. What is the light reflex? So you need to be aware of what is light reflex. Light reflex, if this is the quadrants what you are breaking, this is the anterior and this is the posterior. This is the superior, this is the inferior what you are having. Anterior inferior quadrants has a light reflex. It appears like an cone. Okay, this is known as light reflex or cone, you can call it, different terminologies. This light reflex usually will be absent. So remember, it becomes red, it becomes bulgy, and the light reflex will be absent. These are the three important findings of the tympanic membrane, what you need to be aware of. Sometimes what happens, it can cause perforation and the pus can come out into the external ear and the debris can be seen in the external ear. Presence of debris in the external ear doesn't always mean it is an otitis externa. So you need to closely examine the tympanic membrane. Tympanic membrane is erythematous, it is bulging, there is loss of light reflex, and there is a perforation. So it is a middle ear infection which is causing the spillage of the pus through the perforation of the tympanic membrane into the external ear. What about the antibiotics? There are nice guidelines when to give antibiotics, when not to give antibiotics. None of the below what is mentioned here are present. Do not use the antibiotics. Okay, if there is an ear discharge, because you can visualize the ear discharge because there is a perforated tympanic membrane, then usually backup is preferred. If the kid is under 2 years old and both his ears are infected, backup is preferred. Systemically unwell, or the symptoms or signs are suggestive of a more serious condition. Okay, there might be associated, for example, meningitis might be present, or he has a risk for complications. For example, because of his comorbidities, he has a congenital heart disease, he has a chronic lung disorders, or he is immunocompromised for any reason. In all these circumstances, immediate antibiotics is preferred. When I say backup, what do I mean by backup antibiotics? Here, if they do not improve within 3 days, or if they deteriorate or worsen, the symptoms are worsened in last 3 days in any day. For example, within 1 day, the symptoms got worsened, then immediately take the antibiotics. That is the backup antibiotics what we are talking about. First choice, Here it becomes amoxicillin. If they're allergic to amoxicillin, clarithromycin is preferred. In pregnant women who are allergic to amoxicillin, then you go ahead with erythromycin. If no perforations are there, okay, for the pain, you can give eardrops which has analgesia and anesthetics, like a local anesthetic you can give it. But you need to make sure that there is no tympanic membrane perforation. What about usage of decongestants and antihistamines? Antihistamines like cetirizine, fexofenadate, levocetirizine, decongestants. Do we use this? No, it is not recommended. It is not helpful at all. Especially in otitis media, do not use it. It is useless. Mastoiditis. Mastoiditis is the infection of the posterior part of the ear. To be more precise, posterior or behind the ear, there is a part of the temporal bone known as mastoid. If this gets inflamed or infected, then we call it as an mastoiditis. Okay. Due to this infection, what happens? It pushes the pinna forward and outwards. That is important. It pushes the pinna forward and outwards. Most of the time, it is secondary to the acute otitis media, a complication of an acute otitis media, and eventually can result in intracranial infection. So you need to take this seriously. How on examination, what do you see? Exactly what you're seeing in the picture. There will be some amount of erythema, that is redness, swelling will be present here over the mastoid process. So this is the mastoid process, what you are seeing. Because the pinna is pushed forward and outwards, the external auditory canal might be narrowed. That is important. Do not forget, it might be narrowed on examination. Most of the time, they present to the ED saying that there is a failure to the treatment of acute otitis media because it has got complicated, resulting in mastoiditis. This patient needs to be admitted. Everyone gets admitted here. We need to take it seriously because it can cause an intracranial infection. So admit them, start on them on a broad spectrum antibiotics and immediately involve the ENTs. Admission also will be under the ENT surgeons. Cholesteatoma. Again, it is a complication of recurrent middle ear infections. Because of recurrent middle ear infections, what happens? It starts erosion. Erosion will result in accumulation of keratinized tissue. So you can see this is the keratinized tissue which is got accumulated. This is known as cholesteatoma. Okay, this is the normal ear what you are having. Here you can see this is the cholesteatoma. This is the keratinized tissue which has got accumulated here. That is important for you to pick it up. In the history, usually they'll give an history of recurrent middle ear infection. Complications, again, it can spread to the surrounding structure, which is an intracranial infection it can cause. What are the clinical features? Recurrent otorrhea, discharge, foul smelling it will be. Because it is a recurrent infection and cholesteatoma is developed, they classically will have unconductive hearing loss. Along with it, they can have an vertigo, headache, and tinnitus. Sometimes it can cause compression over the facial nerve, resulting in facial nerve palsy. On examination, you see this keratinized tissue, which appears like a granulation tissue. What you can do in the MED department, you can just refer to the ENT surgeons. So refer to the ENT surgeons. So this, what you're seeing is a real picture here. What you're seeing is the cholesteatoma. It is important. Tested in the OSCE exams, can be tested in your SBA exams also. Tympanic perforation. Tympanic perforation usually happens if there is a direct trauma. Direct trauma to your tympanic membrane can cause. Or base of skull fracture. It's a finding of a base of skull fracture. Or it might be because of a barotrauma. Okay, any changes in the pressure can result in barotrauma. For example, deep sea diving. How do they present? They'll have reduced hearing, not complete loss of hearing, reduced hearing, and some amount of blood can be seen. You need not do anything. It heals very well by itself. Don't do anything. Just tell them to keep the ear clean and dry. Because if they pour the water inside, it can go into the middle ear and cause the infection. Just ask them to follow up with the GP. Nothing to worry about. It usually recovers 100%. And nothing needs to be done for this. Traumatic auricular hematoma. This is commonly seen in wrestlers. It is also known as cauliflower ear. So this ear, what you're seeing, it is also known as cauliflower ear. Commonly seen in wrestlers who hold their ear and pull it, resulting in this. What do they do? Traumatic auricular hematoma is nothing but accumulation of the blood between two layers. The two important layers, what you need to be aware of, this is the perichondrium. So what I'm drawing is the perichondrium. Perichondrium, and behind what the structure is present, this structure is the cartilage. The cartilage is an avascular structure which derives the blood from the pericardium. So this accumulation of the blood separates the pericardium from that of the cartilage. So what is important? If you leave it as such, cartilage can undergo an avascular nephrosis because it doesn't have its own blood supply. It depends on the cartilage. So what needs to be done in these circumstances? Or how do we treat an traumatic auricular hematoma or cauliflower ear? Put a needle here and do an aspirate. After doing an aspirate, tight dressing needs to be done over the ear, because if you just leave it as such, it will rebleed again. So tight dressing is important. Once you're done and tight dressing, then you will ask them to follow up with the ENT specialist. That is important. That's how you will be managing this patient. Epistaxis. Bleeding from the nose is known as epistaxis. Epistaxis is broadly classified into anti-epistaxis and posterior epistaxis. Anti-epistaxis, 99% of the time, is from the Little's area, also known as Kessel-Black's plexus, where four arteries come and join together. That is the commonest spot here. Posterior epistaxis is commonly seen in an elderly person and difficult to manage these individuals. Investigation-wise, they might have a significant blood loss, so blood group cross-matching, clotting profile, and CBC is recommended. But clotting profile, it should be ordered when the patient with epistaxis, unless shouldn't be ordered. Okay, not regularly, do not get a clotting profile unless they have some coagulation disorders like factor A deficiency, they have it, or they have an hemophilia. Then you go ahead and get a coagulation profile. Do not routinely get to each and every patient. What are the risk factors for nosebleed epistaxis? That is high blood pressure, previous episodes of bleeding from the nose, patients who are on anticoagulants like warfarin or heparin or rivaroxaban, apixaban, previous cauterizations, any bleeding disorders, history of recent traumas, any upper respiratory tract infection, especially which causes crusting, any foreign body in the nasal cavity, cocaine users, heavy drinking, and long-term alcohol intake, deviated nasal septum. All of these are the risk factors for having a nosebleed. How do you manage these patients? It is important. First thing what we ask them is do an first aid measure. First aid measure is just to pinch the soft part of the nose for 10 minutes. Continuously pinch it for the 10 minutes. The commercially available clips are also available, which you can place it, or you can just ask the patient to soft part or the tip of the nose needs to be compressed for 10 minutes. It works wonders with an anti-nasal bleed. Posterior nasal bleed, it doesn't affect at all. It is useless in the posterior nasal bleed, but it is very difficult for us to differentiate. Along with the compression, you can ask them to place an ice cube in the patient's mouth. Why ice cube in the patient mouth? It causes vasoconstriction. It can help to stop bleeding. If the bleeding has stopped, you will again basically observe the patient for 15 minutes and discharge them with advice. The advice what you will be usually giving is prescribe them on an antiseptic cream like Naseptin will be prescribed. Why? This prevents the recurrence of bleeding, especially in the children, and it is as effective as doing an cauterization, chemical cauterization. That's why it is always recommended that you prescribe and topical antiseptic creams, especially in the pediatric age group, before you discharge them. Next one is you wear an PPE. If the bleeding doesn't stop by doing a first aid measure, you wear an PPE, make sure you have a good light source, remove any clots from the anterior part of the nose. Okay, ask them to gently blow. If required, do a gentle suction and remove all the blood and the clots which are present in the nasal cavity so that you have a good visual. Then use an cotton wool, soak it with adrenaline and tranexamic acid and place it there. Okay, usually that stops bleeding. If that doesn't stop bleeding, again, remove it. Make sure the nose is clean, doesn't have any clots. You have a good light source. Then visualize if there, can you visualize any bleeding arteries there? If you can visualize the bleeding spot, then do a chemical cauterization using a silver nitrate stick. When you're doing a chemical cauterization, be very careful. You can cause septal perforation. If you cauterize more, you can cause septal perforation. It is recommended that cauterize till it appears gray in color. Do not cauterize till it appears black in color. Do not cauterize on both sides of the septum, nasal septum. It can cause perforation. Important, tested previously in the exam. If it stops, then what you do? Then discharge advice. What we again observe for 15 minutes. Sorry, observe for 15 minutes. Then the discharge advice of a nasal antiseptic cream, which you have discussed. This picture depicts the chemical cauterization. So it is just a stick. Okay, it will be like a matchstick. Where you are seeing the bleeding spot, just place it there. Chemical reaction will happen, resulting in cauterization. So don't place it there for a longer duration. Just place it there for less than a few seconds, basically, till it turns gray in color. That is enough. Do not wait till it turns black in color. What if all these measures are not successful? Then you go ahead for an anterior nasal packing. If that doesn't work, then you nasal pack both right and left nostrils. If that also doesn't work, then it is an posterior nasal bleed. Urgently involve the ENT, and you can use commercially available posterior nasal packs. Okay, rapid Reno or Merosil, you can use it to stop the bleeding. So when you're placing an anterior nasal plaque or you're placing bilateral anterior nasal plaques, they need to follow up with the ENT within 24 to 48 hours for the assessment and removal. So this is a commercially available one, what I'm talking about. If it is a posterior nasal bleed, which is not stopped even within bilateral anterior nasal packing, then you need, or you are forced to do an posterior nasal packing, then you need to admit these individuals under the ENT. Before going even to the first aid, what is the usual recommendation? The usual recommendation is you need to do an ABCD assessment for this patient. That becomes important. Why to do an ABCD assessment for this individual? Because there might be significant amount of blood loss might be present. So make sure the patient is upright because the bleeding is from the head and from the nose, from the head, anywhere it is from face and head. If it is bleeding, we always make sure the patient is upright because they can aspirate. Any mouth bleeding or any nose bleeding, make sure the patient is upright. There are two types, as I told you, a Merosil and there is a rapid rhino. Merosil is as good as traditional ribbon gauze packing. Okay, so this is good. But the best one is rapid rhino. So here what you're seeing is a Merosil. When you pour a water here, it swells up and has a tampon effect. It is as good as a ribbon gas packing. You can use it. But rapid rhino is the preserved one. So what you're seeing is a rapid rhino here. So you insert it and it has a balloon. So you can inflate it by pushing some saline or by pushing some air into it. Why this is more advantageous? It is more comfortable to the patient. One thing that is important, more comfortable to the patient. Another thing it is very important here is when you're removing it, it is easier to remove because you can deflate it. Just suction it back. So all the air or the saline what you're used to inflate it, you're suctioning back. So easy to remove it because it becomes small. Merosil, it remains in the same size. You cannot deflate it. Those are the important changes. So given in the option, always choose and rapid rhino over and Merosil over and ribbon gauze packing. Ribbon gauze packing is outdated. Either you're using Merosil or Rapid Rhino. Which one is preferred? Rapid Rhino is preferred. Posterior nasal bleeding, we always go ahead and admit. What are the other indications to go ahead and admit the patient? If it is a traumatic nasal bleed, the patient is hemodynamically compromised with the systolic blood pressure being less than 90. He previously had a nasal packing which was removed only 7 days, or within 7 days he had a nasal packing. He's on any anticoagulant like warfarin, heparin. Hemoglobin levels are less than 10 in this individual. Uncontrolled hypertension. Significant comorbidities are present. Any social circumstances? Or the patient has a personal preference, he's scared, he lives alone, it is the midnight time, he wants to go in the morning. Yes, at that point of time also you need to go ahead and admit the patient. Remember, no follow-up is necessary for the patients in whom the epistaxis is either stopped spontaneously, first aid measure, or cautery alone. So once you do a nasal packing, only follow-up is required. So if you are doing only anti-nasal packing and it has stopped, then follow up with the ENT in 24 to 48 hours. If I'm not wrong, yes, 24 to 48 hours. If it is posterior nasal bleeding, then it's the indication to go ahead and admit the individual. Advice on discharge. If you're planning to discharge, for example, first aid has worked and you're planning to discharge, ask them not to blow the nose. It can dislodge the clot. So 1 week, no blowing nose. If you're sneezing, it will increase the pressure and it can dislodge the clot. So open your mouth to keep the pressure on the lower side. Do not eat anything hot and spicy or alcohol. Do not consume alcohol for next 2 days because it causes vasodilatation. Vasodilatation can result in triggering the rebleeding again. Do not increase the pressure by lifting something heavy or straining, especially if you're constipated. Do not stray a lot. Do not bend over. Vigorous activity should be avoided for a week's time, and do not pick the nose, especially if you're having cold and there are crusts which are formed. Do not pick it. It can cause rebleeding. Vertigo. Usually the patient presents with some amount of dizziness. Dizziness is a vague term what the patient says. Dizziness means two things. Either they feel like they're gonna fall down. This is nothing but pre-syncope. I don't know, doctor. I feel like I'm gonna lose my consciousness. I feel like I'm gonna fall down. This is pre-syncope and you treat it like a syncope what is studied in the cardiology chapter. Next one is patient says I have the spinning sensation. I feel like things are rotating around me. I'm rotating around the things. So spinning sensation. Spinning sensation is known as vertigo. Okay, you need to be very clear that is he meaning the vertigo or is he meaning pre-syncope? He's gonna fall down. So basically, they say dizziness. Dizziness can mean both. So you need to be clarified that, then go ahead. Whenever a patient presents with an vertigo, your duty in the emergency department is to differentiate between an peripheral vertigo and central vertigo. That is the most important duty for you in the emergency department, is to differentiate between an peripheral and central vertigo. What is a peripheral vertigo? Peripheral vertigo, it is nothing to do with the brain. So something is wrong either in your ear or something is wrong in the third cranial nerve. Then it is known as peripheral vertigo. Peripheral vertigo onset, both are kind of sudden, you cannot really differentiate. Severity of vertigo, it is more severe in peripheral, but you cannot hardly differentiate. Nausea and vomiting is more severe in peripheral vertigo because the spinning sensation is more. Ear are required to maintain the balance. When the spinning sensation is there, you're not maintaining your balance. So whenever there is no balance, you tend to have nausea and vomiting. That is more frequently seen in peripheral, but cannot differentiate. Auditory symptoms are present, it is highly suggestive in peripheral. If CNS symptoms are present, it is highly suggestive of an central cause. Head impulse test. If it is abnormal, that is when positive cascade is present, it is more suggestive of in peripheral vestibular neuritis to be more precise. Central, it will be normal. Head impulse test will be normal. Nystagmus, I'll be studying in the next slide. Most of the time it is peripheral, it will be more horizontal, unidirectional or vertical. Vertical, rarely rotational or vertical it will be. Vertical or bidirectional it is more likely to be in central cause. Skew test, nose skewing and vertical skew. Vertical skew is highly suggestive of a central cause. These three tests are very important, which can be done at the bedside. It is simply known as hint test, where HI stands for head impulse, N stands for nystagmus, T stands for test of skew. What is skew test we'll be seeing here now. So you will close one of the, you'll ask the patient to look forward and fix his gaze and close one of the eyes. Okay. Then suddenly you will uncover. When you uncover, both the pupils will be at the same alignment. But if the skew test is positive, that is vertical skew is present, you ask him to look forward and fix his gaze and you cover one eye. You remove the eye. When you remove the eye, it is one of the pupil is on the lower side, specifically the one which was covered. And slowly it goes back to the normal position. Slowly it goes back to the normal position. That's why it is known as vertical skew. Slowly from down, it is going slowly upwards into the normal position. That's why it is known as vertical skew, highly suggestive of and central nystagmus. What is head impulse? I'll be explaining you when I'm talking about vestibular neuritis. Nystagmus, how to differentiate between peripheral and central. Peripheral, usually it will be horizontal in direction. Central, usually it will be vertical in direction. Effect of gaze. If they're looking in the same direction, regardless of the direction of the gaze, okay, it will remain in the same direction. It will not change. What do you mean by same direction? Two things you need to understand in an nystagmus. One is fast phase, another one is slow phase. So you can see here in the image, it goes rapidly this side and slowly it is going back to the other side. Rapidly where it is going, that is known as fast phase. So the fast phase is towards this direction. Slow phase is in this direction what is present. So this is the slow phase what the patient is having. So the direction, the fast phase direction will not change. Doesn't matter where he is seeing in the peripheral vertigo, but it can change in the central vertigo. That's why it is known as bidirectional vertigo. Fast phase, if you're seeing on the left side, the fast phase might be on the right side. If you're seeing on the right side, the fast phase might be on the left side. So it is changing. This is known as bidirectional. That is not seen in peripheral vertigo. Effect of gaze. When you're seeing towards the fast phase, for example, this patient has fast phase this side and the patient is looking at this side, it will get worsened. It will not have any effect on the central vertigo. The gaze effect will not be there. Fatigue is seen in peripheral vertigo. Fatigue is not seen in central vertigo. Effect of fixation. If you ask the patient to look at one place and fix their gaze, this might reduce the nystagmus, which doesn't happen in central vertigo. It persists with fixation. It doesn't disappear with fixation. Causes of vertigo. All these are peripheral vertigos. And all these are central vertigos. Central vertigos, something is wrong in the CNS. It can be an infection, it can be a stroke, or it can be a vascular insufficiency, or it can be a subclavicular steal syndrome, or post-traumatic, or it can be a multiple sclerosis. Something is wrong in CNS, the central nervous system. If it is a peripheral, then this what we need to think about. Acoustic neuroma, certain literature says it is central, certain literature says it is peripheral. What I have taken the classification is from Oxford Handbook of Emergency Medicine, which classifies it as an acoustic neuroma as an peripheral vertigo. How do we treat it? All these cases needs an symptomatic treatment. So in the emergency department, first you need to make them symptomatically better. So you can use various drugs, what is being mentioned. Usually we use an antihistamine with an anticholinergic effect like cyclizine, or we use an antiemetics like an prochlorperazine. Which one is preferred? Prochlorperazine is preferred because it is available in IM. That means you can give it intramuscularly. Cyclizine or cinnarizine is available perorally. So you need to give it perorally. So if he is having symptoms of nausea and vomiting, and if he pukes out, then it may not be effective. The patients who are experiencing vertigo, it is advised them not to drive till the symptoms are completely disappeared. And what you have mentioned should be mentioned in your nose, and it has to be communicated to the GP also about the driving. So each of the peripheral vertigos, what we'll be seeing here, first one is BPPV, which stands for benign paroxysmal positional vertigo. What happens here? So this is the picture of an inner ear. Inner ear has something known as semineural canals. So these are all semineural canals. In this semineural canals, there are some debris which gets deposited. Whenever the debris gets deposited here, the fluid which is present in the seminal canals cannot flow appropriately. If the fluid cannot flow appropriately, it causes imbalance. Whenever there is an imbalance, you get that spinning sensation and can end up having nausea and vomiting. That's why to make a diagnosis, we do a test known as Hallpike test. To treat, we do a maneuver known as Epley's maneuver. So just remember the names, that is sufficient. Okay, it is not important to remember how do you do it. That is more tested in the OSCE exam. When do we refer to the ENT? When you're not able to perform an Epley's maneuver. That is a treatment of PPPV is Epley's maneuver. You cannot just do it because the patient is very symptomatic, not cooperative. Epley's maneuver, you have done 2 attempts, you have tried, it is not effective. Has been having these symptoms on and off since last 4 weeks, or had more than 3 episodes, similar episodes. These are all indications to go ahead and refer. How do these patients usually present? It's a vertigo, so vertigo symptoms will be there. But it is an positional. Only in certain positions he'll have vertigo. In some other positions, he'll not have vertigo. He'll be completely fine. Not have vertigo at all. Remember that. Only in certain positions. When I turn to the left side, I have vertigo. When I turn to the right side, it completely disappears. That is the classical presentation what you're having. That's why it is known as paroxysmal. Meniere's disease. These are chronic disorders. Most of the time, they would have had the diagnosis of a Meniere's disease. They come with acute exacerbation of Meniere's disease. What basically happens in Meniere's disease, as I told you, there is a fluid inside the semilunar canals. This fluid is known as endolymph. Endolymph, the secretion will become increased. So endolymph will be on the higher side, resulting in increase in pressure. Increase in pressure causes the vertigo in these patients. So classically, how do they present? A ringing sensation known as tinnitus, a fluctuating hearing loss, and peripheral vertigo. This triad is the classical triad of Meniere's disease. Vestibular neuritis. Vestibular neuritis, as the name suggests, is the inflammation of the vestibular nerve. That is the inflammation which is causing it. Why inflammation? Secondary to an viral infection. So in the stem of the question, they would have given an viral infection. 3 days, 4 days, 1 day, 2 days back, he had a sore throat, suggestive of a viral infection. So they will give a clue suggestive of a viral infection. They will not have any neurological signs and symptoms in these patients. When you do an head impulse test, which is also known as ocular vestibular reflex, it will have a positive cascade. What is this? So normally what you do is you ask the patient to fix his gaze. Hold his head as shown in this image and suddenly rotate to one side, left or right side, doesn't matter. His gaze will remain in the same way what is shown here in the picture. So where he was fixed it, he would have still been fixing at the same position itself. When they will be having an positive cascade, or when do we call it as an abnormal test or a positive test? You ask them to fix it. You turn. You turn, the eye also turns towards that side. As you see in this picture, eye also has turned towards this side. Then what happens? Slowly it gets back to the where you have asked them to fix it. Okay, it might take a fraction of a second to get back to this. So eyes have moved and come back. This comeback is known as corrective cascade. Okay, this corrective cascade is classically seen in vestibular neuritis. The confusion is between BPPV and vestibular neuritis. Both have positional symptoms. The differentiating factor is in vestibular neuritis, the symptoms are always present. Okay, change in position will not cause disappearance of the symptoms, but it can cause worsening of the symptoms. On the right side, when I turn, worsening of the symptoms. When I turn to the left side, I feel better, but the symptoms are still persistent. Contrary to the BPPV, if I turn to the right side, symptoms are worse. If I turn to the left side, symptoms disappear. Disappear. If they're still present, it is more suggestive of vestibular neuritis. Disappears, it is suggestive of in BPPV. Acute labyrinthitis. Acute infection of an inner ear is known as acute labyrinthitis. Okay, so inner ear is getting inflamed, so hearing loss will be there in these patients. So they can have ear pain, headache, fever will be present there. When you do an otoscopy, must be performed to look out for any signs of infection. For example, tympanic membrane might be inflamed because of the involvement of the middle ear. You never know. That's why you need to involve it. What is the treatment? Again, symptomatic treatment here. If hearing loss is there, ENT needs to be referred to the individuals. Acoustic neuroma, it is a tumor. Okay, it is a tumor of Schwann, the outer covering schwannoma. It's also known as vestibular schwannoma. It is commonly seen in CP angle. So this is the CP angle what you are having. Okay, commonly seen in cerebropontine angle. This is the cerebropontine angle, commonly known as CP angle. Surrounding that, there are various cranial nerves, especially the 5th, 6th, and 8th cranial nerves are present. So there might be signs and symptoms of this cranial nerve also present. Classically, they will be having a spinning sensation with sensory neural deafness. If present, you need to always think of acoustic neuroma, and they usually develop over months, if not years. Not like something which happens rapidly. Something happens rapidly, unlikely to be an acoustic neuroma. Which develops over months and years, think of an acoustic neuroma. Look out for other cranial nerve involvement. Look out for sensory neural deafness. This kind of summarizes everything what we have learned so far. BPPV, as I told you, episodic in certain positions, it will be absent, there will be no hearing loss. Vestibular neuritis, again, no hearing loss, but it is persistent. A viral infection will be present, a positive cascade on an ocular vestibular reflex, also known as head impulse test. Acute labyrinthitis, hearing loss will be present because it's an inner ear infection, hearing loss will be present here. Meniere's disease usually presents with a triad of tinnitus, fluctuating hearing loss, and peripheral vertigo. Acoustic neuroma, vertigo, and sensory neural deafness developed over months. You need to think of an acoustic neuroma. Also look for other cranial nerve involvements. This we have already learned. This is nothing but again summarizing in different words. How do we know it is an conductive hearing loss or it is an sensory neural deafness or sensory neural hearing loss? What we do two tests. One is known as Rennes test. Another one is known as Weber's test. In Rennes test, what we do is we strike the tuning fork, keeping over the bony prominence behind the ear. That is over the mastoid process. And ask the patient, when you stop hearing it, let me know. Once he stops hearing it, we place this tuning fork in front of the ear. If they are still able to hear it, then we call it as an air conduction better than the bone conduction. If he's not able to hear it when you place it in front of the ear, that means you placed it behind the ear. He has said, I have stopped hearing. Then you place it in front of the ear. He says, I'm not able to hear it. That suggests that bone conduction is better than the air conduction. Bone conduction is better than the air conduction is seen in conductive hearing loss. Air conduction better than the bone conduction is seen in two conditions. Either it might be normal, there is no hearing loss at all, or it might be seen in sensory neural deafness. Next one is a Weber's test. What we do in Weber's test, we strike the tuning fork and place it on the vertex. That is the middle of the forehead, you place it. And ask him whether he is hearing better in any one of the ears or he's hearing equally. He's hearing equally. That means there is no lateralization, we call it. Okay, if there is no lateralization is present, then it is normal. If he's able to hear it better in this ear, for example, he's able to hear it better in one ear, and this ear is the affected ear. So he's able to hear better in the affected ear. He's complaining about that ear, and he's able to hear better in that ear. What is it suggestive of? It is more suggestive of an conductive hearing loss. Okay. We will imagine here, affected ear is this, but he's able to hear normally, or he is able to hear better, or it is lateralizing to this ear. That means he's lateralizing to the normal ear. Then it is suggestive of an sensory neural deafness of the affected ear. Let me repeat it so that there is no confusion. Weber's test is important. People get confused here. Weber's test. Lateralization, we use the term. Lateralization means, is he able to hear better in any one of the ear? No, both ears he is able to hear equally. That means it is normal. Next terminology what I'll be using here is the affected ear. So he's complaining of complaints are in this ear, and he's able to hear better in that ear. Then it is a conductive hearing loss. Affected is this ear, but he is able to hear better in this ear, which is normal, doesn't have any symptoms. Then it is suggestive of an sensory neural deafness of this ear, the affected ear. The same thing has been summarized here. Important, go through it, listen twice or thrice. Once the video is uploaded, it is important, test it in the exam. Persistent unexplained hoarseness of voice or unexplained neck mask, think of laryngeal CA. Okay, whenever like this scenario is given, think of laryngeal CA. Presbygosis is nothing but when you get older and older, the inner ear has certain hair-like structures known as cochlear hair cells. There will be loss as you grow older and older. Can result in bilateral sensory neural deafness. Scoliolithiasis, nothing but stone. Okay, stone can obstruct the salivary glands or the outlet of the salivary glands. This is most of the time seen in submandibular glands. So whenever they salivate a lot, usually we salivate a lot whenever the sore things like lemon you are having it, you salivate a lot, they'll have a severe pain because it is obstructing the outflow. Ludwig's angina. Ludwig's angina is nothing but necrotizing cellulitis below the tongue, that is in the submaxillary, submandibular, and sublingual region. Why do they develop? They usually 99.99% of the time develops or the infection spreads from the tooth infection. That is a dental infection. So some dental infection they would have mentioned in the stem of the question. So this is the important terminology what you need to be aware of and pick it up. Some dental infection, they are having it. Post-dental infection, they end up having this presentation or necrotizing cellulitis below the tongue level in the submaxillary, submandibular, and sublingual region. Think of an Ludwig's angina. The problem here is because the infection is getting developed, the tongue is pushed upwards and outwards. So it can cause airway obstruction. So this is the important thing. It can cause airway obstruction. So any signs and symptoms of an airway obstruction is present. For example, drooling of the saliva is present. Difficulty in swallowing is present. Stridor is present. What do you do in the circumstances? Immediately shift this patient to the resuscitation bay. Okay, immediately shift to the resuscitation bay. If SpO2 levels are on the lower side, connect them on the high flow oxygen. Next thing is involve the ENT and anesthetic because he has an impending airway compromise. If there is an airway compromise, it will be a very difficult intubation. That's why ENT and anesthetics needs to be involved immediately. Now the patient is completely stable. Nothing is suggestive of an airway compromise. At that point of time, what we do? It is recommended that you go ahead and get an CT scan done to see the extent of the necrotizing cellulitis and whether an abscess is formed which requires an drainage. Okay, surgical drainage most of the time will be required. So get an CT scan. Before getting a CT scan, make sure you're given IV antibiotics, shift to the CT scan, get a CT scan done and involve the ENT surgeons for drainage. Mumps. It's a viral infection of the mumps. Viral infection caused by mumps usually involves the parotid gland. So you can see here, cheek in front of the ear, a parotid gland is swollen, known as parotiditis. Okay, main symptom is this parotid gland is swollen, facial swelling, and pain will be present. Other symptoms, because it's an infection, fever, headache, myalgia can be present like in any other viral infections. Complications are important. It can cause Inflammation of the test is known as orchitis. It can cause inflammation of the ovaries known as uveitis. Can spread infection to the surrounding structures, resulting in meningitis and hearing loss. Remember, it is a notifiable disease. It spreads through respiratory droplets like coughing and sneezing. It spreads through respiratory droplets. Now we are entering into the ophthalmology. Anatomy is important in ophthalmology. The anatomy here, what we are looking at here. So this structure, what I'm drawing here is nothing but cornea. Inside the cornea, what you're having, this one, this is the iris. Iris is the one which gives the color to your eye. All right. Behind the iris, what you're having is the ciliary body. Ciliary body has this tentacle-like structures through which the lens is suspended. Between the iris, there is an opening. This is known as pupil, which allows the light to fall on the lens. Whenever the iris constricts, becomes small, the pupil size enlarges, allows more and more light to come in. Whenever the pupil, whenever the iris relaxes, that is dilates, the pupillary size becomes smaller and smaller. That is important. If it becomes smaller and smaller, the pupil size also decreases. Iris dilates, that means iris relaxes, the pupil size becomes smaller. The ciliary body and iris together is known as anterior uveitis. The posterior uveitis is choroid, what you're seeing here. This is the posterior uveitis, choroid, what you're seeing. The white thing, what you're seeing is the sclera, what you're having. This is the optic nerve which takes the impulses. So this red thing, what you're seeing is the retina. Retina has specialized cells which converts the light into the electrical impulses so that an image is formed, and these electrical impulses are transmitted through the optic nerve to your occipital lobe where an image is formed. This whole structure behind the lens, what you're having, has a clear fluid known as vitreous body. Okay, vitreous body, 99% of it is formed by the water and 1% is formed by the hyaluronic acid. Here in this part, there is another liquid known as aqueous humor. This aqueous humor is produced by the ciliary body, goes through it, comes out here and gets drained in this angle that is known as iridocorneal angle. Angle between the iris and the cornea is known as iridocorneal angle. This much is very important to understand the pathologies what we'll be learning. Two terminologies I'll be using. One is visual field. Okay. Another terminology I'll be using is visual acuity. What is visual field? Visual field is, for example, you can see so much. Okay. So I can see a chair which is kept here, a table which is kept here, a sofa which is kept here. This isn't something normal, what is known as visual field. Some persons with visual field is decreased. So I can see only the table and the sofa what is kept here, but chair I cannot see. So on this side, if you consider this as a right side, the visual field is decreased. That is known as visual field. What is visual acuity? Visual acuity is you cannot see clearly, blurring it is present. For example, someone asks you to read it from a for object and for letters which have been written. Usually we use an Ishihara's chart. Ishihara chart, while you're reading, it looks blurry. I cannot read the last line, which you can as a normal person, normal vision. That is acuity. You cannot read properly. There's a blurring of the letters what you're reading. That is visual acuity. Visual acuity, you need to look for both far vision and the near vision. Next thing I'll be talking about is the red reflex. What is red reflex? If I take this one, whenever the light passes, whenever light you flash it from an arm distance using an otoscope, the light passes through the pupil, falls on the lens and falls on the retina. And some of this light is reflected back and it appears red in color. Okay, so the pupil will appear red in color. This is known as red reflex. Red reflex can be lost if it is obstructing for the light to fall on the retina. Various things which can cause. The opacity of the lens has increased. For example, cataract. So it is not opaque because of the cataract. There is a bleeding in the vitreous body, vitreous hemorrhage. There is a retinal tear, so it cannot fall on the retina at all. So in these conditions, red reflex will be absent. Another few things I wanted to talk about. Pupillary reflex. What is pupillary reflex? When you flash the light on the pupil, what happens? So when you flash the light on the pupil, usually the pupil dilates. So you bring the light in, that is known as the pupil should move in, that is known as light reflex. Okay. What is concentric light reflex? When you flash the light on the pupil on the normal eye, but you're visualizing the other eye. If there is a constriction of the pupil is seen in another eye, then that is known as constrictional reflex, which is intact. So let me repeat it again so that there is no confusion. We'll go to a clear slide here. So consider this two as an eye. Consider this as an torch, what you are having, and you're flashing the light on this. And you're visualizing this eye itself. The pupil becomes small. That means the light reflex is intact. This is an direct light reflex. Direct we call it because you're flashing the light on that eyeball, eye, and you're looking for the constriction of the pupil of that particular eye itself. Next thing is, you flash the light on this eye, but we are visualizing the constriction on this. So if the constriction of the other eye is present where you're not flashing the light, this is known as constrictional reflex, which is intact. Okay, if there is no dilatation of the pupil is seen, if there is no constriction of the pupil is seen and the pupil size remains the same, constrictional reflex is absent or it is not intact. These are all the terminologies what I'll be using here. So hope there will be no confusion while I am talking about these conditions. So let us start with palsy. First thing what you need to understand here, the extraocular muscles, that means the muscles which are attached to the eyes, have certain amount of tone. All the muscles in your body has certain amount of tone. If there is an injury, for example, this one, sixth cranial nerve, abducent nerve, there is an injury. So there will be paralysis. That means loss of tone of the lateral rectus will be there. Loss of tone will result in what? Loss of tone is there. So this becomes floppy. This has certain amount of tone. So when you ask him to see forward, he'll not be see forward. This becomes the normal eye position when you ask them to see forward. So when do they have an diplopia, double vision? They'll have an double vision when you ask them to see towards the affected side. Why? When you ask them to see towards the affected side, the medial rectus will relax and it will allow the pupil to go to the middle. But it is not able to pull it towards the lateral side to see on the affected side. So the pupil has to go here. It is not able to go because lateral rectus is paralyzed. That's what exactly is seen here. So when you ask to see forward, because the lateral rectus tone is lost here and the tone of the medial rectus is intact, this will be the normal eye position. When you ask them to see forward, forward gaze. When you ask them to see towards the affected side, they'll have double vision because the normal eye will move towards this side, but the abnormal eye is just in the middle. So the image from this is different from the image formed here. So they end up having double vision. This is suggestive of an lateral rectus palsy, or it might be suggestive of an injury to the abducent nerve, that is the sixth cranial nerve injury. Next one is the superior oblique. Superior oblique, also known as superior oblique extraocular muscle supplied by trochlea, that is the fourth cranial nerve. So superior oblique. Superior oblique, what is the functionality of the superior oblique? Superior oblique pulls the eyeball inwards and downwards. If the tone is lost, what will happen? It will go to the opposite direction whenever you ask them to see forward. So that's what it has happened. It has gone outwards and upwards when they are when you ask them to see forwards. What happens? When do they get an double vision? Whenever you ask them to see downwards and inwards. That's the function. Downwards and inwards. It will not come downwards and inwards. It will remain in the neutral position at that point of time. And this will go downwards and inwards. This is at the neutral position. So one is at the neutral position, one is at the downwards and inwards. Different images are formed, resulting in diplopia. So usually the classical history is whenever I climb stairs, when you're climbing stairs, what do? You look at your feet. At that point of time, your eyeballs are downwards and inwards and ended up having double vision. Here what happens? Here is the injury to the third cranial nerve. Third cranial nerve supplies all the extraocular muscles except the lateral rectus and superior oblique. Okay, so combined effect will result in what? When you ask them to see forward, the eye will be downwards and outwards. The eye will be downwards and outwards. Important. Along with it, what it will, sorry, when do they have an double vision? They have in double vision when you ask them to look at towards the normal ear. Remember normal ear here. Lateral rectus, it was towards the affected normal eye. Sorry, not ear, eye. Whenever you ask them to look towards the normal eye, they will have double vision. Whereas in the lateral rectus palsy, whenever you ask them to look towards the affected side, they had the double vision. That's the differentiating factor you need to be aware of. Eye position here is downwards and outwards. Important. Along with this, what you need to remember, this is the third cranial nerve if you are imagining. are surrounding to the third cranial nerve. They are the fibers of the parasympathetic nerves. These parasympathetic nerves also can be get affected. So if the parasympathetic nerves are affected, sympathetic activities unopposed will result in dilated pupil. So they can have associated dilated pupil. Okay. And they can have ptosis also. So remember, they can have dilated pupil, ptosis with the eye position when you ask them to look forward is downwards and outwards. These are all the classical features what you need to be aware of. This one we have already learned. Whenever there is an blow, a punch to your eye socket can result in inferior orbital floor fracture as shown here, resulting in inferior rectus muscle getting entrapped. If the inferior rectus muscle gets entrapped here, whenever you ask them to look upwards, they'll not be able to look upwards, or the eyeball is not able to move upwards. The normal side will move upwards, resulting in double vision, resulting in diplopia. So diplopia is seen whenever you ask them to look upwards. Everything summarized in these tables here so that it is easier for you guys to remember. Red eye. There are various causes for the red eye. For example, it can be conjunctivitis, corneal aberrations, corneal ulcers, acute angle closure glaucoma, anterior uveitis, cellulitis, subconjunctival hemorrhage. Each one of this will be seen. Okay, depending on the presentations, you can guess what it might be. For example, it came in contact with persons who had similar symptoms. Think of infective conjunctivitis. These patients have an atopic illnesses, like he's a known case of hay fever, he's known case of asthma. Think of an allergic conjunctivitis. He's a contact lens, he wears a contact lens. Think of an corneal infection or ulcer might have happened whenever they use a contact lens. He is a known case of inflammatory bowel disease like an ulcerative colitis, or he is a known case of joint disorders, especially ankylosing spondylitis. So anything related with HLA-B27, think of an scleritis or an anterior uveitis, especially HLA-B27 anterior uveitis, scleritis or other conditions which I'll be discussing in coming up slides. Depending on the redness of the eye, which part of the eye is red, you have differential diagnosis. If it is generalized, as you're seeing in this picture, more suggestive of an conjunctivitis. If it is more localized, like you're seeing in this picture, it is suggestive of an scleritis. It is more around the cornea. Okay, this is known as perilimbal or circumcorneal. Circumcorneal erythema or perilimbal injection is present. Think of two differential diagnoses. Either it is an anterior uveitis or it is an acute angle closure glaucoma. Whenever it is completely red, like a paint color, what you're seeing in one part of the sclera, think of subconjunctival hemorrhages in this individual. Subconjunctival hemorrhages are treated symptomatically, nothing needs to be done. Unless it is in pediatric age group, you need to think of an non-accidental injury in the pediatric age group. Conjunctivitis, the first thing which causes redness of the eye, it can be because of an bacterial or an viral infection. Bacterial like strep pneumonia, H influenza, Staph aureus. Viral, most of the time it is an adenovirus. It is very difficult to differentiate between a bacterial and viral infection. That's why what we do is everyone gets an antibiotic here as we are not able to differentiate. Sometimes it might be because organisms which are causing STDs like chlamydia and gonococcal. These patients will have urogenital symptoms, or it might be in the neonates just born. I'll be discussing about neonatal conjunctivitis in coming up slides. Okay. In those patients, think of an chlamydia or gonococcal infection. Sometimes it might be allergic. So usually they'll be having an associated asthma or associated hay fever will be present in these individuals. So using topical antihistamines will be effective in these individuals. Advice for persons who are wearing contact lens. Dispose of the contact lens what you're having currently. Do not wear the contact lens till you're completely recovered. Advice on the patient, do not share towels and pillows because it is highly contagious. It can spread very rapidly. If the symptoms do not settle, you need to come back within 5 days. Ophthalmia neonatum. As I told you, STDs in the neonatum, it can be present. This is known as ophthalmia neonatum. Okay, this when they come in direct contact during birth. Okay, whenever there is a vaginal birth and they come in direct contact, can result in Neisseria gonococcal infection or chlamydial conjunctivitis. Okay. Neisseria gonorrhea is the bacteria you suspected if they presented within 1 to 4 days of the life. After 4 days, that is from 5 to 14 days, think of a chlamydial conjunctivitis. Out of this, Neisseria gonorrhea's infection should be taken very seriously, needs to be admitted, IV antibiotics will be required. Nevertheless, both of the conditions, it is recommended that urgent pediatric and ophthalmology input will be required. Okay, especially if it is in gonococcal ophthalmia. If it is in chlamydial, you can discharge them with oral antibiotics. Okay, before starting on antibiotics, make sure you have collected cultures and you have done and gram staining, collected a swab for the gram staining, and NAT test has been done before you start them. It's a serologist test, NAT test is. Corneal trauma. Okay, any foreign body can get flicked into the eye. Sometimes it might be flicked with a very high velocity. Okay, some dust particle can come into a very high velocity and can damage your inner structures like lens. It can damage iris. It can damage. It can go as an vitreous hemorrhage. Okay, you need to be aware of that. Whenever you're looking for a foreign body, always avoid the upper eyelid. Sometimes it will be stuck over the upper eyelid, and the symptoms will be like whenever I close my eyelid, I feel some pricking sensations. I feel some foreign body sensation. When I keep my eye open, I'll not have the symptoms. That is suggestive of the foreign body stuck behind that of the upper eyelid. Fluorescence will help you. It will really pick it up the foreign body if you're having difficulty to visualize. Visual acuity might get decreased in these individuals. Pupillary irregularity might be present whenever there is this causing an injury to the iris, can have an pupillary irregularity. High FEMA can be present. Vitreous hemorrhage can occur in this individual. This what you're seeing like a ring-like structure here. This is known as rust ring. When a foreign body has gone in, over that if the epithelial tissue gets grown, then it becomes a rust ring. Whenever you're suspecting a rust ring, it is recommended that you ask them to follow up with the ophthalmologist. How to remove a foreign body? Just irrigate it with a normal saline and see whether it will be helpful. That will be the step one. If that is not helpful, what we do is we usually place them on some amount of local anesthetic drops. Okay, it is not a must, just to make the patient comfortable. Okay, so it is not a must that you need to pick up in step 2. Step 3, what you do is you try to remove it with a cotton bud. If that doesn't help, then you use a needle of 23 gauge, very fine needle, along with the direct visualization using a slip lamp, try to remove it. If that is also unsuccessful, then you directly refer to the ophthalmologist. Topical antibiotics is recommended to everyone. Okay, we want to prevent prophylactic antibiotic is given to everyone. Especially the persons who are using contact lens, it is recommended that you add up an anti-pseudomonal coverage. That means add up quinolones in those individuals. Previously, it was recommended that dilate the pupil with cyclopentolate, it will reduce the pain. No longer it is recommended. For pain, what we do is we give oral analgesia. iPad is not recommended. It can worsen the condition. It can worsen the pain and vision. Driving advice, ask them till your visual acuity is completely normal. Do not drive. Tropical steroids, topical anesthesia, absolutely no and no. It will hamper with the healing. Tetanus prophylaxis is certainly not recommended unless there is an associated corneal abrasion. Otherwise, tetanus prophylaxis, do I need to see the tetanus status and for foreign body? No, not required. Unless there is an corneal abrasion associated with it. Penetrating traumas. As I told you, a foreign body can go and get penetrated. This is what you're seeing is an iris prolapse. It has got an injury to the iris and iris has come out here. Sometimes the particle might be deep inside. So getting an X-ray will be helpful. X-ray, when you are getting it done, it is always advised that you ask the patient to look upwards, get an X-ray done. Look downwards, get an X-ray done. Okay, so that you do not miss the foreign body. For penetrating traumas, it is recommended that you place the patient on an eye shield, not on an eye patch. This is an eye shield. This is a plastic one. It will not cause any pressure over the eye. This is gauze pieces. If you just apply over the gauze pieces tapes, it can cause pressure over the eye and it can worsen the situation. Use some oral analgesics for these patients. Tetanus prophylaxis needs to be given if it's a penetrating trauma. That is penetrating foreign body is present. An urgent ophthalmology reference is required here. Blunt traumas. Blunt trauma can cause dislocation of the lens. Here you can see lens was supposed to be here. It has got dislocated here and it can appear in this manner. Sometimes it can cause iridodialysis. The thing, but the iris has given away here. Okay, that's why you're seeing black color. It has given away. The attachment has gone there. The iris has given away. That is known as iridodialysis. Sometimes there might be accumulation of the blood. Due to the gravity, it has settled downwards. So this what you're seeing is a blood. This is known as hyphema. And sometimes it can cause retrobulbar hemorrhages seen in major traumas, which we have already discussed in our major trauma chapter. Ocular burns, mainly with chemical splashes, what we are talking about here. So it can be because of an acid or alkali, both. For both, the treatment is you first irrigate with large amount of normal saline. Okay. If required, if the patient is uncomfortable to irrigate, then you can use local anesthetic drops so that the patient is cooperative enough so that you can irrigate as much as possible till the pH comes back to the normal range. If the pH doesn't come back to the normal range, then you need to refer to the ophthalmologist, or you once the pH comes back to normal, we always what we do is we do a slit lamp examination using an fluorescent stain. If you observe some corneal abnormalities, basically if you observe any corneal burns, corneal ulcers are present because of these chemicals, then you need to immediately refer to the ophthalmologist. CS spray. CS spray is commonly used by police to incapacitate the persons. Okay, the spray, the police personnel will have it. First step, what we do is we usually blow it. Okay, blow dry the eye to disperse particles and reduce the irritation. So directly do not irrigate them. If you directly irrigate them, there can be a chemical reaction. So the advice here is do not directly irrigate them. First blow dry. How to blow dry? Just place a fan behind or at an angle of 45 degrees, you place a fan so that the air is blown over the eye. After you have done this, after around 2 to 3 hours delay, then you can rinse it. Hydrofluoric acid, hexafluorine is the most effective to decontaminate the solution. Super glue can be, sometimes kids are playing, they use the super glue and it has resulted in closure of the eyelid. What do you do at that point of time? Ask them to wash gently with warm water, apply a patch, and usually I will open in a couple of days, 1 to 4 days it might take. This is a super glue what I'm talking about. Keratitis and corneal ulcers, they are vaguely one and the same thing. Whenever there is an giveaway in the epithelial lining of the cornea, then we usually call it as a corneal ulcer. They can appear like punctate dots or round shaped it can be, or it can be having dendritic like this. Whenever it is dendritic, it is highly suggestive of an herpes simplex infection. Symptoms will be photophobic. Whenever there's flash of light, they'll have quite a bit of pain. Injected eye, red color eye, painful eye, and unilateral symptoms will be present. Vision wise may be affected, may not be affected, depends on the ulcer location, size of the ulcer. Urgently, you need to refer anyone who has an keratitis and corneal ulcer. So everyone who has an corneal ulcer keratitis, the step one is the reference to the ophthalmologist. Even in corneal ulcer caused by herpes simplex, the step one is not to start the treatment. It is to refer to the urgent referral, is refer to the ophthalmologist is the first step. So in corneal ulcers, remember that step one is refer to the ophthalmologist. The preferred drug what to use whenever there is a corneal ulcer caused by an herpes simplex suggested by an dendritic ulcers is ganciclovir ophthalmic drops. Okay, you can use other drops also like trifluridine ophthalmic drops or acyclovir ophthalmic drops can be used. Systemic drugs like an acyclovir giving orally or IV is not preferred. Topical ophthalmic drops is the preferred treatment. Superficial keratitis. It is also known as arc eye. It is also known as snow blindness. This usually happens whenever there is an exposure to the UV light. Whenever there is exposure to the UV light, commonly seen in whom? Who go to a lot to the beach side and they do not wear sunglasses, or it is seen in welders, okay, who are not wearing their eye protection. It is commonly seen in these persons. How do they present? They commonly present with painful eye and it is watering and involuntary closure of the eyelids. Involuntary tight closure of the eyelids is known as blepharospasm. On examination, you get this classical appearance, lot of punctate kind of corneal lesions you'll be seeing. So what you do, you give NSAIDs eye drops, oral analgesia for the pain, eye patch. Cyclopentolate is not recommended frequently in this cases. Cyclopentolate is kind of outdated. What you need to tell them, it will resolve spontaneously within 24 hours, if not in 48 hours. Nothing needs to be done. Just pain management, symptomatic management, that is NSAID eye drops or oral analgesia, give it, eye pad, that should be enough here. Acute angle closure glaucoma. So what happens here? As I told you previously, the ciliary body produces the aqueous humor. It passes through here and enters here and gets drained into the trabecular meshwork. This is the angle between the cornea and the iris. If this angle becomes acute, that means if this angle becomes small, what will happen? This aqueous humor will not get drained. It will get accumulated here only, resulting in increased intraocular pressure and the symptoms will start appearing. So what can cause this? Acute angle. This is the acute angle what you're having. Acute angle can be caused by shallow anterior chamber, pupillary dilatation, or lens growth. Is it a true emergency? Absolutely, it is a true emergency. Always measured for the intraocular pressure, it will be on the higher side. They classically presents with mid-dilated pupil. Pupil will be mid-dilated, and the erythema is commonly not in this picture, it is seen everywhere, but it is commonly seen around. This is known as circumcorneal erythema. Circumcorneal erythema. Those are the very typical. Mid-dilated pupil not reactive to the light. Direct light reflex will be absent here. Circumcorneal erythema and raised intraocular pressure. These are the typical features what we'll be seeing. They might have vague symptoms, like systemic symptoms like headache, abdominal pain, nausea, vomiting. Eye symptoms like eye pain and decreased visual acuity. These are all vague symptoms. It will not suggest anything. But mid-dilated unreactive pupil, circumcorneal erythema, raised intraocular pressure is highly suggestive of an acute angle closure glaucoma. What are the strategies here? Reduce the aqueous humor production. That can be done by using acetazolamide or timolol, which is a beta blocker. Okay. Reduce the intraocular pressure. You can do it by giving an osmotic diuretic like an mannitol. Okay. Along with it, you want to constrict the pupil. If you constrict the pupil, you can see here. Let me clear it so that you have a clear image. If you constrict the pupil, what will happen? The iris will come forward. Okay. Iris will fall forward. That means iris will enlarge and it becomes thin. The angle will open up. That is importance of it. So constriction of the pupil is done using an pilocarpine, but pilocarpine will not be effective if you give it in the first hour. So wait for an hour's time after you started the treatment, then you give pilocarpine. Rest of the treatment is symptomatic, that is analgesia. Obviously, you need to refer to the ophthalmologist. Why do you refer to the ophthalmologist? For the definitive management, that is an iridotomy or iridectomy. So just scrape off a little bit of iris. That's what they'll be doing, the ophthalmologist. So the angle opens up and there is good drainage of the aqueous humor. Anterior uveitis, very important, multiple times tested in the exam, so do not ignore it. Anterior uveitis, anatomically, we are already aware of. It includes two structures, anterior uveitis, ciliary body, and the iris. What happens here? Due to the inflammation of the iris, strictures can form, or the adhesions can form underneath the lens. Okay, this is important. Because the adhesions are formed, the pupil cannot constrict and dilate. Constriction dilation requires iris iris contraction and relaxation. That cannot happen because the strictures are formed. So it becomes irregular. When you see it becomes, pupil becomes irregular because adhesions are formed between the iris and the lens. So the pupil becomes irregular. Because it is the inflammation of the iris, in front of the iris, you can see plenty of inflammatory cells. So because of presence of these inflammatory cells, they'll have some amount of floaters or haziness will be there. That will be the complaints of the patient. Another thing, because of these adhesions which are formed during accommodation, what happens? People constrict. So during accommodation, they'll have quite a bit of severe pain. Pain which worsens during accommodation. Okay, remember this much is very important. What about the intraocular pressure? Remember, it is decreased. Why? Ciliary body is involved. Ciliary body is the one which secretes the aqueous humor. If the ciliary body is involved, what will happen? There will be less and less aqueous humor production will be there from the ciliary body. That's why the intraocular pressure will come down, will not increase. Management here, urgent referral to the ophthalmologist. On ophthalmologist advice, only you can use steroid drops. You cannot give it on yourself because it is an acute inflammation. Steroid drops might work, may not work. But whenever you are using a steroid, it has to be advised from the ophthalmologist in any condition. You're not giving steroids for the treatment of the eye without the ophthalmologist request. Remember that is very, very important. Next important thing is anterior uveitis is associated with HLA-beta-7. If you remember when I spoke about the inflammatory bowel diseases, or when I spoke about what ankylosing spondylitis, I told these are all HLA-B27. Here again comes anti-uveitis is also a part of HLA-B27 serotype. Scleritis. Scleritis is the inflammation of deep episcleral vascular plexus. Okay, commonly associated with rheumatoid arthritis or venous granulomatosis. These are the commonly they are associated with. What it causes? It causes thinning of the sclera. Thinning of the sclera will result in bluish color. Because the sclera is thin, they are prone for globe rupture. Okay, globe can perforate and can rupture easily in scleritis. So it is a true emergency. You need to take it. And usually they'll be having a painful eye movement because all the extraocular muscles gets inserted over the sclera. Sclera is inflamed. So whenever you move your eye, sclera is pulled, will result in pain. That's why they are having painful eye movements. When you palpate the orbit, it will be quite painful and reduced visual acuity will be seen in this individual. Management wise, referred immediately. Systemic NSAIDs for the pain. Steroids are given only on the ophthalmology reference. You need to evaluate for the autoimmune disorders like rheumatoid arthritis and venous granulomatosis, which are commonly associated with scleritis. Episcleritis, on the other hand, it is the superficial episcleral vascular plexus which are got inflamed here. Here it was deep. There it is superficial. That's the differentiating factor. It's a self-limiting condition. Nothing needs to be done. Only symptomatic management with topical or oral NSAIDs that will be sufficient. Classically, they present with an erythema which is localized. Orbital cellulitis versus and periorbital cellulitis. Orbital cellulitis needs to be taken seriously. It has to be treated like sepsis by admitting. If you do not treat it seriously, it can cause vision loss, complete vision loss. It is not very common for the infection to spread into the eyeball. It is prevented by a structure known as orbital septum. You can see orbital septum is present over the superior eyelid and the inferior eyelid also. So this prevents the spreading of the infection into the eye. How to differentiate from preseptal cellulitis and orbital cellulitis? Whenever any eye symptom is present, think of an orbital cellulitis, admit the patient. As simple as that. For example, they are having an chemosis. This is a chemosis. Also, they are having an proptosis. This is also in chemosis what they are having. This is known as blepharospasm, painful, difficult in opening the eyes. Okay, involuntary closure of the eyes is known as blepharospasm. Or these patients usually will have painful eye movements, restricted eye movements, reduced visual acuity. All these features where eye is involved, always think of an orbital cellulitis. Along with it, what do you need to think of? Along with it, if there is an preceding eye trauma or infection, septal cellulitis is common, not orbital cellulitis. Whenever there is a preceding remote infection, then the orbital cellulitis is common. This preceding eyelid trauma or infection, why it is not common? Because of present of this structure, what we have spoke, orbital septum, that prevent the spread of the infection. So surrounding it was infected, so it is present in the eyelid. Unlikely because orbital septum is present, which prevents the orbital cellulitis. It can cause any complications. It can cause infection of the surrounding structures like infection of the optic nerve, optic neuritis, osteomyelitis, meningitis, orbital abscess. Okay, it can cause severe infection resulting in sepsis. It can cause cavernous sinus thrombosis or central retinal artery occlusion. It can cause so various complications it can cause. That's why we need to take it seriously and treat it with broad spectrum antibiotics. Immediately involve the ophthalmologist. If you're suspecting an abscess formation, always get a CT scan. High grade fever not responding to the antibiotics, then you need to suspect abscess might be there. Get a CT scan done. When a surgical drainage will be required, a surgical drainage will be required. Afferent pupillary defect is developed, or visual acuity is reduced, or antibiotics fails to improve the symptoms. In these conditions, definitely you need to refer for surgical drainage. Few of the other eye conditions, what you need to be aware of. Blepharitis. Blepharitis is nothing but matted. This is what you're seeing, matted eyelashes, what you're seeing here. Matted eyelashes, you usually treat it with an topical antibiotics like chloramphenicol and refer to GP to follow up. This is known as external hordeolum. This is known as internal hordeolum. External hordeolum, what happens here? Sorry. External hordeolum, root of the eyelashes gets infected. So hot water compression should be enough here. Nothing needs to be done. Usually because of blocked glands might be there. Here, what happens here? This is because of blocked meibomian gland, also known as Calizon. Okay, that causes infection. Here, for this infection, topical antibiotics like chlorphenicol along with oral antibiotics is preferred. If they develop abscess or the nodule is affecting the vision, then you need to refer them to the ophthalmologist. Last one is dacrocystitis. This is nothing but lacrimal sac infection what you're having. If this is this bad, like abscess is formed, then drainage will be required. You need to refer to them. Earlier one is not as severe as seen in this pictures. Then you can treat it with co-amoxiclav. Usually it resolves well. But it has got worsened like this, what is present. It is large, it is later stage. Then drainage will be required. Refer to the ophthalmologist. Sudden visual loss. Sudden vision loss is broadly classified into whether it is a painful or painless vision loss. Painless easily can be remembered as retinal. So central retinal artery occlusion, central retinal vein occlusion, retinal detachment. So if the cause has a retinal in it, remember that it is painless. If it doesn't have retinal in it, it becomes painful. When I say painful, for example, migraine causing a sudden vision loss, it's a headache. Temporal arteritis, it's a temporal region which is having a headache. Okay. Optic neuritis and glaucoma, obviously the eye pain will be present. It is not always an eye pain. It can be an headache also when we say painful vision loss. First one, what we are seeing is a central retinal artery occlusion. Central retinal artery is an end artery. Okay. So if it gets occluded, there will be loss of the vision will be there. So complete retina becomes pale. So when you do an fundal examination, complete retina becomes pale. Only one spot will be bright in color, that is known as cherry red spot. So this is a classical finding what you see on a fundal examination. On a pupillary examination, what you will be seeing? Directly when you flash the light, the pupils will be sluggishly constricting or it will not be constricting. Conjunctional reflex will be intact. So when you flash the light on the opposite eye, this will constrict. But on the same eye, if you flash, it may not constrict or it might be sluggishly constricting. There are various treatments which have been proposed, like rebreathing carbon dioxide, which can vasodilate the retinal artery. Timolol eye drops, which is a beta blocker, which can reduce the IOP. You can reduce the intraocular pressure by reducing the aqueous humor protection by using an acetazolamide. Globe massage might dislodge the thrombus or dilate. Vasodilators like an sublingual GTN can dilate and dislodge thrombolysis, hyperbaric oxygen, various things. These two are not frequently used. Frequently, we use one of these methods. But remember that none of the methods have been proven to be effective till now. Central retinal vein occlusion. There are various risk factors for a vein occlusion. It might be old age, chronic glaucoma, atherosclerosis, hypertension, or polycythemia. They will present with decreased visual acuity, that is blurring of the vision, and afferent pupillary defect will be there. Conceptual pupillary light reflex will be intact, or the effect will be intact. Fundoscopy will present classically like this, what you're seeing here. Dilated tortuous veins. So these are the dilated tortuous veins, what you're seeing. The red color are the retinal hemorrhages. This yellow color, what you're seeing, are cotton wool spots, along with papillary edema can be seen in this patient. These are the typical things what you'll be seeing. Treatment-wise, mainly you want to prevent the macular edema to develop, either by giving steroids, biological agents, or laser therapy. And you need to optimize the risk factors. All this treatment, steroids, biological agents, or laser therapy to reduce the macular edema is done by ophthalmologist. So urgent referral to the ophthalmologist is required here. Vitreous hemorrhage. Okay, hemorrhage in the vitreous body. Vitreous body, as I already told you, it contains 99% of the water and it has only 1% of hyaluronic acid, which is a collagen. So it is completely clear. Okay, there are various risk factors. Main thing is underlying pathology is the vessels which are there, the blood vessels which are there, they become very brittle and they break. Or it is because of the trauma. Trauma we already know. In diabetes, what happens? The actual veins gets occluded. New vessels are formed, which will be brittle. Same thing happens in sickle cell disease also. In subarachnoid hemorrhages, this is a syndrome itself known as Terson syndrome. What are the symptoms? Because blood is there, light cannot fall directly on the retina. It is falling on this. So what will happen? There can be decrease in visual field depending on where exactly it is present. Visual acuity, blurring of the vision can be seen. Some amount of floaters or something is floating or haziness, those kind of things also can be seen. Loss of red reflex will be there because light cannot pass and fall on the retina. Normal, this is a normal red reflex what you are having. This is also normal. This is abnormal. You're not seeing red thing. This is absence of red reflex. So what you'll make the patient to sit on the chair and neck is hyperextended so that the blood gets settled down and immediately refer to the ophthalmologist because most of the time vitreous hemorrhage is associated with an retinal tear and closely monitor for intraocular pressure which can be increased because of the active bleeding. Retinal detachment. Again, various risk factors like elderly diabetes, short-sightedness who are having after and trauma, retina gets detached. Remember, vitreous hemorrhage and retinal tears, that is retinal detachments, are most of the time together what you see. The presence with a classical history, they feel like a curtain is coming down across their vision. Okay, flashes of light, floaters might be present, they're not specific. A curtain developed across the vision, a curtain is falling down. That is important. Red reflex is absent. Retina may be difficult to visualize. Partial retina might be visualized on fundal. Visual acuity, if macula is involved, visual field defects usually is seen in this individual. Immediately refer to the ophthalmologist for reattachment here. Optic neuritis, inflammation of the optic nerve, very commonly associated with the multiple sclerosis, MS it is. They classically present initially with and red desaturation. That means they cannot appreciate between the pink, red, and orange. They cannot differentiate. All appears red for them. Okay. Relative afferent pupillary defect will be there. Optic discs may be swollen. So papilledema will be present in this individual and afferent pupillary defect will be seen in this individual. This we have already discussed in the neurology chapter. It's just to completion purpose I put across here. Amrox fugus. This is very much similar to that of the transient ischemic attack. What happens here? Transient loss of ocular vision will be there. And usually it lasts for a few minutes, like 5 to 20 minutes will be there. Why it happens? Because temporarily there is an occlusion of the artery. Temporarily obstruction of the central retinal artery most of the time, there is temporarily occluded. It might be because of an emboli. It might be because of a temporal arteritis, acute angle closure glaucoma, or raised intraocular pressure, or hypercoagulability. So what is your job? To find out the underlying cause and treat the underlying cause is your job. Amaurosis fugax doesn't say it is a disease by itself. This is the underlying cause for the temporary arterial obstruction, which has caused in temporary loss of the vision, monoocular temporary loss of the vision, which lasted for few minutes. You need to evaluate what might be the cause. Is it because of an acute angle closure glaucoma? Is it because of an hypercoagulability? Is it because of an emboli thrown from an atrial fibrillation? You need to figure it out and treat the underlying cause. Usually we start them on aspirin. Like in TIA, we start them on aspirin because most of the time it is an emboli. If you are having any questions, you can type it in the chat box. We'll be entering into the recall questions. A 23 years old came to the ED department with an abdominal pain. He is suffering from a glandular fever and prescribed a symptomatic treatment. Sorry, GP said that he might be suffering from the glandular fever. Might be, it's not a definitive diagnosis. Prescribed symptomatic treatment. Confirm what test you will be using to confirm the diagnosis here. So which test you will be using to confirm the diagnosis, what they are asking here. So remember here, abdominal pain whenever is present along with a sore throat. So sore throat plus abdominal pain is always an EBV infection, that is infectious mononucleosis, until and unless proven otherwise. This individual is more than 12 years of age, 23 years. That's why we are getting a monospot test done, which is also known as Paul Burnell's test or atrophile antibody test. They all mean one and the same. Do not get confused. Next question is abdominal pain he has presented with. Can't it be a splenic rupture? Yes, it can be a splenic rupture, but it is not the diagnosis. Okay, that's why we're not getting the ultrasound scan done here. They're asking about the diagnosis here. Diagnosis is infectious mononucleosis. Complication of it is an splenomegaly. Abdominal pain usually is because of splenomegaly. If splenic rupture is there, he'll be in the resuscitation bay. The presentation will be quite severe. A 4 years old child with active seizures he had. Okay, and the child has an the child is in post-ictal stage, image is shown below, likely nerve involved, they are asking. You can see one pupil is constricted, another pupil is dilated. So which is the nerve which is most likely involved? So this is the right side, this is the left side. It's a third cranial nerve surrounding to the parasympathetic nervous system, fibers are present. If that gets lost, there is unopposed sympathetic tone resulting in dilatation of the pupil. So this is the left ocular or left third cranial nerve involvement, what you're seeing in this individual. A 19 years old female has presented with nosebleed, pinned the cartilaginous part of the nose to stop the bleeding, which was unsuccessful. Cauterize the bleeding spot. Bleeding has stopped. After cauterization, bleeding has stopped. What complication do you suspect from cauterization? Is the septal perforation straightforward? Sudden loss of right vision, headache and vomiting he is having. What is the diagnosis? It's a painful vision loss. So it cannot be anything with retinal, and retinal. Vitreous hemorrhage. No. Vitreous hemorrhage and glaucoma. Along this, which one causes painful? Glaucoma is the one which causes painful vision loss. Following is indicative of a central cause of vertigo. Unidirectional, peripheral, bidirectional vertical nystagmus, central, tinnitus, more peripheral, head impulse test, positive vestibular neuritis, that is peripheral again. Nystagmus remains in the same direction regardless of the direction of the gaze. So this is known as unidirectional. To be more precise, it is known as unidirectional. Unidirectional is commonly seen in peripheral. Bidirectional, if the fast phase changes, then it becomes central. Redness in the right eye, image is given. Symptoms is associated with which condition? Image, what you can see, as you can see, irregular people. That is enough for me to label as an anti-uveitis. But I see something here wrong. What is this? This is known as hypophyron. Nothing but pus has got accumulated. It's an inflammation, infection which has happened. This is the pus what you're seeing here. So which symptoms is associated with this condition they are asking? Blurring of the vision, there is loss of visual activity? No. Purulent discharge? No. Permanent vision loss? No. Mid-dilated people seen in acute angle closure glaucoma. Pain during accommodation, it causes constriction on the pupil. This is an symptom what you will be seeing in anti-uveitis. So the diagnosis here is anti-uveitis. Complaints of difficulty in swallowing and neck pain, 56 years old person, and underwent an dental tooth extraction and image is given. What is the diagnosis? This is a classical image with a dental history. Whenever they say, always pick up and Ludwig's angina. What will be the next step for this patient? Make sure the patient is in recess because he's having difficulty in swallowing and immediately involve the ENT and anesthetics. If the patient is desaturating, if the SpO2 levels are on the lower side, give an oxygen supplement for this individual. 10 years old child was brought by his father to the ED department. Fresh blood on the pillow is seen. Tonsillectomy was done 7 days back. So I'm thinking of it delayed. Okay, this is delayed. The kid is tachycardic, no active bleeding, but purulent discharge is noted over the tooth extraction side. Next step. This patient might be having severe infection. So we are thinking of and delayed. Okay, whenever there is a delayed post-tonsillectomy bleed, you are thinking better to give IV antibiotics and get all the investigations done. They can go into sepsis. So option number 5 will be the right answer here. A 60 years old lady brought to the ED department spinning sensation. That means the lady is having an vertigo. Increases when moving and continues even at rest. Head impulse test is positive, Q test is negative. This itself is enough for me to say it is an vestibular neuritis. So is it an vestibular neuritis? Let's see. There is an unidirectional nystagmus on the left side. What is the next step in the management? So this is a diagnosis of an vestibular neuritis. So what do we do for an vestibular neuritis? We reassure them it is a viral infection. We reassure them it will cause subside on itself. Nothing needs to be done. Symptomatic treatment with what? With chlorpromazine, what you're giving here. You can use other drugs also like cyclizine. Cyclizine can be used like antihistamine, anticholinergic drugs like lorazepam, diazepam also can be used. But the preferred one will be chlorpromazine in most of the cases. Sore throat and fever. He is an IV drug abuser. Investigation of choice they are asking. Here is the confusion. IV drug abusers, they can be having an EBV virus. Or this person can be at the high risk of having a group A beta hemolytic streptococci. I recommend you to choose the throat strap for an ASO titers or for strep infection because if it turns out to a pulmonary state or EBV virus, it is an infectious monolingual. If it's positive, also the management remains symptomatic. unless there is an airway obstruction when you'll be giving steroids. Here, you can give antibiotics. That's why throat swab for strep becomes more appropriate answer. Worried mom brought her kid to the emergency department. Apparently, while this morning playing in the garden, mom noticed some change in the eye. This is known as chemosis. Chemosis is typically seen in conjunctivitis, highly suggestive of conjunctivitis. Playing in the garden and it has developed. So, what are we thinking about? We are thinking about more allergic conjunctivitis for this patient. That's why we need to give antihistamine as the eye drops for this individual, which will be most effective here. Is not a feature of anterior uveitis. Perilimbal erythema is also known as circumcorneal erythema. Yes, seen. Irregular pupil. Yes. WBC in the anterior chamber. Yes. Inflammatory cells in the anterior chamber. Pain on accommodation. Yes. Raised intraocular pressure. No. You see an low intraocular pressure most commonly. 45 years old male, blurring of the vision and pain in the right eye. Floaters and headaches is having significant past history of a lower back pain. What is the diagnosis? Lower back pain. So what are we thinking about? It might be an ankylosing spondylitis. So what it might be? HLA-B27 associated disorders. So it might be anti-uveitis. That's all you need to think about here. Image. Just looking at the image, can I make a diagnosis? They're asking which nerve might be involved here. Yes, I can make. There is a ptosis which is present here. And the eye position is downwards and outwards. That is enough for me to call as a third cranial nerve involvement, that is oculomotor nerve involvement. Known case of Sjogren syndrome. Sjogren syndrome is a syndrome where the oral cavity secretions will be completely dry. Okay, dryness will be seen. No saliva will be seen much. Pain and swelling around the mandibular region. Pain is worse while eating. What is the diagnosis? Okay, pain around the mandibular region worse on eating, suggestive of obstruction which is present. This is known as cellulitis. Okay, it's a condition where there is a calculi at the duct of the salivary gland. Most commonly, the salivary gland is involved as submandibular gland. That's why they are mentioned clearly here as submandibular region. And it is very commonly seen in Sjogren syndrome. A 50 years old present with the ED with swelling at the base of the mouth. Third molar teeth is extracted. Vital parameters are within normal limits. What is the next step they are asking? Okay, swelling base with the third molar teeth. What I'm thinking about? I'm thinking about of an Ludwig's angina. So this is an Ludwig's angina the patient is having. Whenever there is a Ludwig's angina, next thing we ask about where there is a compromised airway or not. That is important. Compromise. There is nothing to suggest of compromise, and they are telling the vital parameters are fine. So we're thinking no compromise of the airway is present. That's why we are going ahead and getting a CT scan done and starting on them on an IV antibiotics. If there was a compromise on the airway, then ENT for tracheostomy, possible tracheostomy would have become the right answer. Painful eye movements in the left eye, high grade temperature. What is the diagnosis? Picture has been given. Any eye symptoms are present, always think of an orbital cellulitis, admit the patient, give IV antibiotics because they can cause various complications, including complete loss of vision, permanent complete loss of vision. Image is given. What is the probable diagnosis? Image, what I'm seeing. Here is somewhere tonsil. Behind the tonsil, there is a swelling what is present here. This is known as quinsy. Quinsy is also known as peritonsillar abscess. Risk of airway obstruction is there in peritonsillar abscesses. Sustained injury to the nose, image is given. What is the diagnosis? This is known as septal hematoma. Septal hematoma. The importance of septal hematoma is similar to that what we learned about the cauliflower ear. Here also, it separates the cartilage from the vascular structure which supplies it. Okay, so this blood needs to be drained. If you do not drain it, it can cause avascular necrosis. So you need to drain it in the ED department. A simple nick will be sufficient here. Sore throat, upper abdominal pain. What is the causative organism they are asking? Sore throat, abdominal pain, doesn't matter what the image they are given. Whenever there is a sore throat, abdominal pain, we're thinking of an EBV virus infection causing infectious mononucleosis. So the diagnosis here is EBV. Acute angle closure glaucoma. You tend to avoid certain drugs in these patients. Which of the following drugs needs to be avoided? You avoid any drugs which causes dilatation of the pupil. That means constriction of the iris causes dilatation of the pupil. So you need to avoid all those drugs. So which one it causes? Grossly, what we talk about group of drugs is anticholinergic drugs you will be using. And also you are using an sympathomimetic drugs. You will be using both of these drugs can cause dilatation of the pupil. Here, both tricyclic antidepressant and SSRIs, both can cause this. Okay, that was the feedback what I got saying that both were present. If both are present, both will become the right answer and the question will be deleted from your exam. This can happen. Then the marking will be out of 179 rather than being out of 180. Something flew in his eye. Image is given. What is the diagnosis? You see, the pupil is not round. It has become something like this. The structure is not round here. So what has happened? This an impacted or foreign body has gone, resulted in an iris prolapse. The picture is suggestive of an iris prolapse, usually seen because of a penetrating injury by a foreign body. So impacted or penetrating foreign body. Dendritic lesions are present, suggestive of an corneal ulcer caused by an herpes simplex. They're asking which is the drug of choice or what treatment you'll be giving. Out of this, ganciclovir eye drops, oral acyclovir is not preferred. Systemic drugs are not preferred, which is indicative of an sensory neural hearing loss. Okay, remember that is complaining of an hearing loss in the left ear. That becomes important. So left ear, what are the findings? What will be having? In sensory neural deafness, Rennes test, air conduction will be better than the bone conduction in both left as well as right. Okay. Next, Weber's test. In Weber's test, what happened in sensory neural deafness? In Weber's test, it will be lateralizing to the normal ear. Normal ear here is the right. So lateralization to the right ear will be present. First, write it like this. Okay. Or think like this before you choose the answers. Lateralizing to the left, no, it has to be right. So this is wrong, rule out. Rennie's test, air conduction is better than the bone conduction on the left side. Yes, this statement is right. Bone conduction will be better than the air conduction on the left side. No, this is a wrong statement. And this is also wrong statement. This usually suggests you often conductive hearing loss in both this. No lateralization is seen in a normal ear. This is the best way to not get confused in the exam. Cherry red color spot, easily I can make a diagnosis of a central retinal artery occlusion. No confusion at all here. This image is itself enough for me to tell it is a traumatic auricular hematoma, also known as cauliflower here. Important thing is to prevent avascular necrosis, so aspirate, compression dressing, and follow up with the ENT is required here. Commonly seen during wrestling, so that's why they have mentioned punches on the ear. Image diagnosis, very straightforward diagnosis. Dendritic lesions you are seeing. This is the corneal ulcer caused by herpes simplex virus. Dendritic ulcer also you can label it as. 7 years old boy noticed blood on the pillow. Tonsillectomy done 7 days back. Child is still and continuously swallowing. Whenever I told you in pediatric chapter, still is a term in a child. Whenever they mention things, something is seriously wrong. You need to take it very seriously. Seriously wrong. Continuously swallowing. Why do you think continuously swallowing? Because blood is coming in. Kids tends to not spit it out. They continuously keep on swallowing and swallowing and swallowing. So this is an post-tonsillectomy bleed. So first step in post-tonsillectomy bleed is what? Do an ABCDE assessment. Before that, make the patient sit upright. Okay, calm the kid and make the patient sit upright should be the first thing what you'll be doing. Okay, then you will be going according to the steps what we have learned about, because the patient is still quite, blood pressure is still holding on. So you need to see the consciousness level of the patient, then take a call how you go stepwise. Okay, what we have learned, you need to manage accordingly. Which one is indicative of a sensory neural hearing loss? So which side is involved? Again, left side is involved here. So what happens if left side is involved? What do you need to look out for? Air conduction will be better than the bone conduction on both left and right side. There shouldn't be. So lateralization to the left, sorry, left is the affected. So the lateralization on the Weber side will be on the right side. Okay, let us say Rennie's test, bone conduction is better than the right conduction, and Weber's test, lateralization to the affected ear. No, it is a wrong statement. Unable to hear the whispers is not suggestive of any conduction. It's not a very good method to check. Rennie's test, air conduction is better than the bone conduction, lateralization to the normal ear, that is the right ear. Affected one is the left ear. Yes, this becomes the right statement. Complaints of vision loss in the left eye accompanied by the pain. What is the diagnosis? Mid-dilated pupil, usually unattractive to the light. Intraocular pressure will be intraocular pressure will be elevated. Perilimbal erythema present. All are suggestive of an acute angle closure glaucoma. Image most appropriate management plan for this patient. So this is an ulcer. So what we need to give, step 1 is to refer. Step 2, this is a dendritic ulcer, so we need to give them eye drops, like an acyclovir eye drops can be given or ganciclovir eye drops needs to be given. Oral acyclovir and self-referral, no, this is a wrong statement. Same day referral to the ophthalmologist for urgent review. Yes, this is partially right answer, but the step 2 they have not mentioned. Topical chlorphenicol with the GP, it will not work. Topical ganciclovir with self-referral, no, this cannot be. Referral should be the first step. Topical ganciclovir and steroid eye drops we never give on ourselves. That's why the option number 2 becomes right here. Same day referral to the ophthalmologist for urgent referral or review is very important step that needs to be done first. Sore throat, fatigue, abdominal pain. Sore throat and abdominal pain, EBU infection. Amoxicillin given but developed and widespread maculopapillary rash. What's the most likely diagnosis? Infectious mononucleosis. This rash is commonly seen in EBV virus infections whenever you give amoxicillin. 2 months old kid with a fever of 38 degrees Celsius. You examine while reveals and bulging tympanic membrane suggestive of an acute otitis media. According to NICE guideline for fever under 5, what is the most appropriate next step? This we have learned in the pediatric chapter. Anyone who is less than 3 years old plus having a fever of 38 degrees Celsius more than or equal to, we go ahead and get an LP done. So perform an LP is there along with other investigations. Also, what we have learned, if you remember the tabular form, the N one, it was here where I had mentioned about less than 3 years old kid. Central cause for vertigo, which one of the following features are suggestive? Nausea and vomiting seen in both, headache seen in both, earfulness seen in peripheral, sudden onset seen in both, left hand incoordination is suggestive of a central cause. This is an cerebellar sign. To be more precise, this is an dysmetria, we can call it, in coordination, or we usually use an dysdiadochokinesia to check for cerebellar signs. Fluorescein stain reveals an corneal abrasion. Next step is prescribe topical antibiotics and pain control, but ideally should have been rough. Urgent ophthalmology reference, prescribe topical antibiotics and pain control. So what we need to do on an urgent basis, they are asking for an corneal abrasion here we are asking. This is not an corneal ulcer. There is a differentiating factor between an abrasion and an ulcer. If it is an ulcer, then I would have picked up an urgent ophthalmology reference. As it is an abrasion, you can prescribe topical antibiotics, pain control will be the right answer. Abrasion doesn't require referral. Ulcers requires referral. 40 plus 6 days neonate. So what does it mean? So the birth was the 40 weeks of gestation. The age of the neonate is 6 days now. Okay, 40 plus 6 days neonate if they mention. Swelling of the eyelids, eye redness, purulent discharge from both the eyes for past 24 hours. Suggestive of an conjunctivitis. So what kind of conjunctivitis are we thinking? Chlamydial, because it has presented after 4 days. So anyone 5 to 14 days it is presenting, it is a chlamydial infection what we are thinking about. On examination, bilateral conjunctivitis, swelling, mucoid purulent discharge is present. What is the next step? So it is a chlamydial. If it is a Neisseria gonococcal, then immediately ophthalmology involvement, IV antibiotics, and admit. For this patient, chlamydial, usually we give oral antibiotics. So obtain eye swab and start oral erythromycin will be the right answer. Maintain orbital hygiene. It is important, but it is not as important as starting them on an oral antibiotics and taking the eye swab for the definitive diagnosis. Prescribe topical antibiotics with follow-up with GP. No, you need to take an eye swab. That is important step. That is not mentioned here. That's why we cannot choose that. Obtain cultures and start IV antibiotics. This would have been the right answer if it is a Neisseria gonococcal infection, which is commonly seen between first 4 days. Reassure patients and parent and observe. This can be catastrophic and result in this can result in orbital cellulitis and loss of vision can occur. So right answer here is option number 3. So that ends ENT and ophthalm chapter. Anyone has any doubts, you can ask me now.